Okay, I think we're going to go ahead and get started. So good afternoon. I'm Heidi Jones. I'm in the Department of Epidemiology and Biostatistics here at the CUNY School of Public Health. We're hosting this month's Grand Round. We're really thrilled to have Dr. Ashley Naimi here. Did I pronounce that? Naimi? Okay. Who is Assistant Professor of Epidemiology at the University of Pittsburgh Graduate School of Public Health. His research falls at the crossroads of causal inference, social epidemiology, and human reproduction. He develops and applies analytic methods to non-experimental data to assess the effectiveness of potential policy interventions to reduce the overall burden of and social disparities in adverse pregnancy and childhood outcomes. I think that we can relate to those disparities as we see them really firsthand here in New York City. A major focus of his current work is the development, use, and interpretation of statistical methods for causal mediation analysis, although I don't think that's what he's going to be focusing on today. He's going to be focusing on some methods to look at per protocol analysis, which maybe we don't think of enough in randomized control trial settings. The end goal of Dr. Naimi's research is to develop targeted, actionable strategies to reduce racial disparities in preterm birth. So we invited him here in part as in one of our doctoral classes. We were thrilled to watch his lecture on Society for Epi Research, where he explained G estimation to us, a topic that we were having difficulty understanding. And so it's really the students that said, hey, he would be great to bring. And so we're really thrilled to have him here today. So please join me in welcoming Dr. Naimi.
Great, thank you so much. So can you hear me well enough? Yeah, great. Okay, so thank you for coming to this talk. Thank you for inviting me to give this talk. It's a great pleasure to be here with you. I'm going to present some work. So I have my fingers actually in a lot of different research pots. What I'm going to be presenting to you today is work that I've been doing with a group at NIH on analysis of randomized trial data. So as was mentioned, I'm assistant professor. I have the privilege of being associated with this beautiful team here. The drawback here is that, as you will probably note during my talk, I will be coughing a little bit. So we do have the luxury of being exposed to patient zero several different times a week. So yes, I apologize for that if it's going to be a distraction. With regards to the work that I'm going to present to you today, I was very fortunate to be able to work with folks at the NIH here. Bob Silver, who's at the University of Utah and is one of the primary authors of the investigators of the study. Robert Platt at McGill University, who did some work, or who's currently doing some work with us on one of the aims of the grants that I'm going to be presenting the work on. And then the rest of these fine people here are actually working at the NIH, and they were the ones responsible for collecting all the data and actually doing the study. So I'm very grateful to them for letting me do this work. And here's just a very brief outline of what I'm going to be talking to you about today. So the fundamental question is about the relationship between aspirin and pregnancy outcomes. In order to discuss this relationship, we're going to get into issues regarding the distinction between an intent to treat effect and a per protocol effect. And now I'm going to present the results that we've actually obtained looking at the per protocol effect of daily low-dose aspirin consumption on pregnancy outcomes in this eager study, which I'll be presenting to you. And so we can get right into it. And really what I'm going to be talking to you about fundamentally is pregnancy loss. Pregnancy loss in the first trimester is actually one of the most common pregnancy complications. Among those who experience a pregnancy loss, there is a 20 to 30% recurrence rate. And it turns out that it's actually, it's not that easy to get pregnant and to stay pregnant, particularly among those who have had a previous pregnancy loss. So the estimated per cycle conception rate is roughly 25%, which is not particularly high. I should also say, at any point during this talk, If you have questions or something's not clear, please feel free to stop me and ask those questions. I'm happy to answer them. I'm also happy to take questions at the end. So pregnancy loss is a problem. This is where aspirin comes in as a potential solution to this problem. So aspirin, as we all know, is a widely available over-the-counter non-steroidal anti-inflammatory, fairly well tolerated, and it's actually known to have beneficial hemodynamic and immunomodulatory effects on reproductive organs. As a result, low-dose aspirin use is actually increasing in perinatal medicine, and there are established guidelines for the prevention of preeclampsia. There are also guidelines for the prevention of pregnancy loss, but only among women with a specific condition known as antiphospholipid syndrome. These guidelines have been published by the American College of Obstetrics and Gynecology, where they recommend LDA in women who are at high risk of preeclampsia, and they also recommend that it should be initiated between the 12th and 28th week of gestation. Did you see that? Okay. So in the absence of high preeclampsia risk, there is actually, and they state this in the guidelines, there is no evidence to support the use of prophylactic LDA for the prevention of pregnancy loss. Right? And this is one of the things that I'm going to try to be addressing with this talk. So part of the problem here is if you actually look at this evidence base that the ACOG is developing their guidelines on, what you'll see is a majority of the studies have been done in which aspirin was initiated roughly at or beyond 12 weeks of gestation, right? Thus missing a relatively important therapeutic window for the prevention of pregnancy loss. This is where the EAGER trial comes in. So EAGER stands for the effects of aspirin in gestation and reproduction. This was a randomized controlled trial that was conducted by the NIH at various centers across the United States between 2007 and 2011. And what they looked at was the effects of preconception initiated low-dose aspirin. So the outcomes of interest were hCG detected pregnancies, pregnancy loss, and live birth, and they were able to recruit roughly 1,200 women into this study. So I'm going to skip ahead a little bit, and I'm going to present the ITT results. So the findings that were based on ITT showed that there was an increased hCG detected pregnancy rate. There was also an increase in the live birth rate. However, there was absolutely no effect on pregnancy loss in this trial. And to give you a sense of this, I'm kind of showing you the intent to treat results here. So you can look at the risk difference column. This is expressed per 100 women in the sample. So among those who were assigned to aspirin versus placebo, there were roughly 4 more live births. There were also roughly 4 more hCG detected pregnancies. However, there really were no decreases in pregnancy loss. So in that paper that they published in 2014 reporting these results, they stated clearly that these results did not provide evidence for changing the current guidelines. There wasn't sufficient evidence for doing that. But there were several questions that arose, right? Several aspects of the trial raised these questions about the aspirin's potential role in optimizing pregnancy outcome and preventing pregnancy loss. Most notably, they observed a degree of noncompliance in the trial, right? So in fact, compliance with the study protocol, women were actually taking the pills that they were assigned to very early on, but as follow-up progressed, they sort of declined. That compliance declined. Right? And one important thing here is that the intent to treat effect does not quantify the effect of low-dose aspirin. It actually quantifies the effect of low-dose aspirin assignment. Right? And so that's one of the questions that was raised. Or this feature raised some questions about what they were seeing. There was another aspect too, which was the timing of aspirin initiation. So a major feature of this study was that women were randomized preconception. This allows us to actually model the timing effects the effects of different aspirin start dates. But again, intent to treat quantifies the effects of a point intervention, at least in the way this study was designed. And so the ITT effect can't really provide any insight on the actual timing of effect, on the actual timing of aspirin initiation. So the two questions that come out of this are as follows. One is, what would the effect of aspirin have been if actually all women took the pills as they were instructed to take in the study? And the next question is, does it really matter if they took aspirin pre-conception versus 6 weeks post-conception versus 12 weeks post-conception versus 20 weeks post-conception, right? And these are the questions that I'm going to answer today. And to do that, I am going to use the eager data, so I'll get into a little bit more details about how this study was designed. So eager was a multi-center, double-blind, placebo-controlled trial. Eligible women were between 18 and 40 years of age and were actively trying to conceive. Women had to have experienced either 1 or 2 documented pregnancy losses in the past. Women were randomized to 81 milligrams of aspirin or placebo, and all women actually received 400 micrograms of folic acid as well. Follow-up was basically consisted of 2 phases. The first was follow-up during the 6 menstrual cycles while women were attempting to conceive. And if they did conceive over the course of these 6 cycles, or during the course of these 6 cycles, they were then followed throughout the entirety of their pregnancy up until 36 weeks. So overall, we were able to obtain roughly 40,000 person weeks of data from this eager study. And we had a lot of information to work with here, which is important when you're trying to estimate for protocol effects, and I'll explain a little bit why later. But so right off the bat, we collected some of the information to adjust for as baseline confounders. So this was information that was collected right at study entry. The outcomes in the study were actually 4 distinct outcomes. One was withdrawal, so women were allowed to withdraw from the study at any time. The other was end of follow-up without pregnancy. So if they proceeded through follow-up for the first 6 menstrual cycles and did not conceive during that period, their follow-up was ended. But if they did conceive, then they had the opportunity to experience 2 additional outcomes. One was pregnancy loss, which was measured using urine tests, spot urine tests for hCG, and then followed up with clinical ultrasound measurements. And live birth was measured using the medical chart. I'll explain a lot more about the time-varying confounder aspect, but we also had a lot of information that was collected regularly over the course of follow-up. So we had the opportunity to adjust for a number of important time-varying confounders, and the one that we focused on were bleeding, because it is associated with aspirin. It's also predictive of the outcomes, and it's likely to influence whether or not women will take aspirin once they've experienced the bleeding episode. Also, nausea and vomiting or gastrointestinal discomfort was recorded. Finally, I have hCG pregnancy here. It's one of the outcomes of our study, but it turns out that in the context of a longitudinal study like this one, some of the outcomes can actually confound the relationship between the treatment and other outcomes of interest. So, for example, in the case where a woman would have gotten pregnant, she may have decided to completely stop taking aspirin in order to, say, protect the baby that was in her. And that is, and obviously hCG pregnancy is very predictive of these outcomes, right? So this is one of those situations where one of the outcomes can serve as a confounding variable as well. So we actually had, a lot of measurements. We were able to actually get down to daily resolution for these measurements. But in order to deal with the data, we summarized on a weekly basis whether any of these were present or not. So we analyzed person week data. Of course, in order to adjust for noncompliance, we had to have compliance measures, and there were actually several strategies that were taken to record compliance over the course of follow-up. The one that we relied on was the bottle weight measurements that were taken at regular intervals. This allowed us to compute the number of pills that were taken in any given week over the course of follow-up. And we deemed, for the purpose of the results that I'm showing you here, we deemed a woman compliant with the protocol if greater than or equal to 5 pills were taken for over a 7-day period. Right? So, in other words, a woman could have missed a couple of days in that week and still been compliant in our study. So one thing to note, 5 out of 7 days is actually fairly high. You know, it's a lot to sort of keep up with. But the important thing here is to know that aspirin does have a very, very short half-life. And this has biological implications for a missed dose. So we wanted to try to create a stringent threshold that would allow us to maintain the blood concentration of aspirin as high as we possibly thought reasonable. Okay, so when we created these compliance measures and started examining compliance over the course of follow-up, we noticed something pretty interesting. So what I'm showing you here is a figure plotting the average compliance over each week of follow-up. So here you can see the proportion of women that are compliant. And I've got 2 timescales here. One is week on study, so time 0 is basically randomization. And you can see that there's sort of a rather precipitous drop in compliance over time. More interestingly, though, I think, is if you plot this from conception week, negative to positive conception week, among those who actually did conceive, you sort of do see that something begins to happen around the time where women are getting pregnant. Almost as if they really did decide to stop taking aspirin once they became pregnant, which is not an unreasonable thought. Okay, so we want to adjust for noncompliance, but how can we do that, right? And it turns out that there are lots of different ways that we can account for this noncompliance. Generally, in the context of a randomized trial, when the treatment is a point intervention, adjusting for noncompliance is relatively straightforward. You can use a whole handful of different methods that typically will all provide the same result, and it's not complicated. A few lines of code and you can do this analysis fairly easily. Unfortunately, when the treatment consists of a series of actions that are taken over a long period of time, such as in a pragmatic trial, like the one that I'm presenting here, accounting for the consequences of noncompliance can become much more complex. So I was pleasant to learn that students here are taught DAGs, so I'm going to show you a DAG to try to explain why accounting for noncompliance here is a little bit more complex. And I'm going to start with this very basic relationship. Right? So let's assume that here X is my measure of compliance in some week of follow-up, J, and Y is an outcome. Let's just say for argument's sake it's live birth. We want to estimate the magnitude of this arrow, the effect of X on Y, right? The effect of taking aspirin. As we all know, we have to think about confounding variables in this particular case, and here I'm going to use the case of nausea and vomiting. So suppose that that week, J, the woman was feeling very nauseous, wasn't feeling very good. Likely she would not have taken aspirin. The probability of not taking aspirin is higher. It turns out also that there is, actually in the eager data, but also other studies as well, an established association between gastrointestinal discomfort and live birth and pregnancy outcomes. So in this particular case, we might consider N to be a confounding variable. The problem is that we have X measured at various weeks over follow-up, many different weeks over follow-up. And it could be that at week J, this woman felt ill because she complied for 7 days out of 7 days in the previous week, right? So in fact, it could be that she was feeling ill because she was very compliant in the previous week. So what's the problem here? The problem is we need to adjust for N in order to avoid any confounding bias between our measure of x, j, and y. But if we do that, we end up potentially blocking part of the association that we're really interested in, the effect of compliance in the previous week on our outcome y. Additionally, if there are any potential unmeasured confounders of the confounding outcome relationship, the relationship between n and y, we could induce what's known as collider stratification bias by conditioning on n. Excuse me.
You encourage us to ask, nausea is a manifestation of early pregnancy.
It's one of the reasons why it's predictive of the outcome. So we were not able to distinguish between nausea early in pregnancy versus nausea caused by aspirin consumption. But, excuse me, this nausea variable is rather artificial. There was actually several different measures that went into it, which included gastrointestinal discomfort that was specifically targeted towards symptoms of aspirin. So taking aspirin every day for several weeks on end tends to lead to certain gastrointestinal issues. So that was our nausea variable, but you're absolutely right. Yeah. It doesn't create any problems for this analysis, though. Other questions? Follow-up is totally complete. We have all of the data. The follow-up was finished in 2011. They handed a very messy data set over to me in 2018, and I spent time cleaning it up and putting it all together. So everything that I'm presenting to you is actually sort of hypothetical in the sense that I'm exploring what the data are telling us about possible interventions, right? So we're not actually going in and intervening on this. Is that what you were asking about? Yes. Yes. Yeah, absolutely. Nausea is not the only variable that serves this purpose, though. I mean, we also had bleeding in this spot, so I could have replaced this n with a b. Bleeding would have been another variable that is potentially related to the outcome of interest here. I actually also could have put hCG pregnancy there, right? So those are our 3 time varying confounders. The nice thing about the methods that I'm going to explain to you is that in the event that these are not actual time varying confounders, we won't get the wrong answer if we use these methods. Right? So they're sort of generalized methods in that they allow us to analyze very simple data structures and very complex data structures.
Did the women know the results of the hCG pregnancy test?
They were informed of the results of the hCG pregnancy test, yes. Yeah, so these were very, so they actually, there was an intensive follow-up period in which they were collecting daily urine samples, and those samples were being analyzed regularly. And as soon as there was a confirmed hCG detection, they were asked to present to the clinic for an ultrasound follow-up. Okay, so this is a problem of if you don't adjust for n, you have confounding bias, and if you do adjust for n or some other variable representative of n, you end up blocking part of the association that you're interested in and also inducing a collider stratification bias. Now, when I say adjusting, I actually mean using, for example, standard regression adjustment. This problem is actually referred to, at least in the randomized trial world, as time-varying post-randomization confounding, or more generally as time-varying confounding. And as a result, we can't use standard regression methods to analyze data that are generated from structures such as the one I showed you. Right? However, we can use what are called G methods, such as G computation, otherwise known as the G formula, or inverse probability weighting. So this is one piece of the problem here, but there's another piece. And that's the piece with regards to the timing of aspirin initiation. So again, ITT quantifies a point treatment effect, right, being assigned at baseline. But it's actually a very important open question in the clinical world, whether or not it matters if you take aspirin very early on in pregnancy or even before pregnancy. So we have the data to answer this question, and so we sought to answer it. This this kind of situation. So, for example, if we wanted to know specifically, does it matter if you take aspirin prior to conception and then nothing after, or following conception and nothing before, versus if you took aspirin throughout, prior conception and post-conception, right? That kind of a question is a question that we call in the causal inference world a time-varying interaction question, because it's basically an interaction between two variables that vary over time, aspirin and conception, right? So again, you can't use standard regression to quantify these things, but actually it turns out that you also can't use IP weighting to answer these kinds of questions. So that narrowed it down for us, and we decided that we were going to use G Computation. So we use G Computation to answer, well, really two questions. This one has already been answered. So first, but I'm going to present it to you because I want to compare these results. So the first question that we might be interested in is, what's the ITT effect? Right? And I'll assume everybody understands this relatively well. Then we define our first per protocol effect. And this per protocol effect is basically as follows. We want to know what would happen if everybody takes aspirin all the time over the course of follow-up versus if everybody takes placebo all the time over the course of follow-up. So very specifically, what is the probability of live birth if everybody were to take aspirin all the time versus if everybody were to take placebo all the time? And our second per protocol effect is what would happen if everybody took placebo up to the 6th week of gestation, and then after that, they took aspirin. And we want to compare that protocol to what would happen if everybody were to just take placebo over the course of follow-up.
I'm curious to what extent there was correlation between compliance and observable socioeconomic indicators.
Great. Observable socioeconomic indicators?
Education,
Yes.
Different things that predict compliance, and then, maybe whether that could indicate some underlying unobservable indicators of conscientiousness that might kind of bias the comparison.
That's a great question. So actually, we did look at the intention to treat effect relative to socioeconomic indicators. The problem is that, unfortunately, most of these women here were from Utah, which meant that they were mostly white and well-educated with median household incomes that were fairly high. We did have some degree of variability there, but it wasn't a great degree of variability. So we're not really able to answer very many questions about socioeconomic status and race in this particular data set. However, one of the aims of the grant that is funding this work is to examine the transportability of these effects. So this is actually a project that I currently have a PhD student who's beginning to make inroads into. So transportability is basically what would this per protocol effect look like if the sample were to look more like, say, the U.S. population instead of only just the population of women in Utah, right? So that's a very important question that I'd like to get at, and where we're doing that work now. Okay, so does everybody understand per protocol number 2? It's basically, we're asking women to take placebo up until some time point, and then switch to take aspirin. And we want to compare that to what would happen if they just took placebo throughout. And the reason is that will give us the timing effect, right, if we can explore this question. So again, I'm going to use G Computation to answer these questions. G Computation is also known as the parametric G formula, slightly different from G estimation, which is used to estimate parameters in a structural nested model. A structural nested model quantifies parameters that look very different from the ones that I'm quantifying here. G Computation is very simple, at least in a 10,000 foot way. It's a generalization of standardization. So if you have learned how to estimate standardized effects, you know exactly what's happening behind the scenes with a G Computation estimator. And in fact, in a time fixed setting, if we were to just have one exposure time point, G Computation is exactly just standardization. In a time varying setting, it becomes a little bit more involved, and we'll get into some of that. So what I'm going to try to do now is explain to you, is to give you some intuition behind how G computation works. So I went and created this very elaborate diagram that hopefully won't confuse you more than anything. So what I want you to do is think about the process that generated our data, okay? And I've got some arrows here in this figure. I want you to think about these arrows as very abstractly as just models. So this, for example, X at week M, this is the compliance node, the compliance variable, right? And the arrow here is, you can think of that arrow as the propensity score model. And so the propensity score is a model for the exposure at time M, conditional on a whole bunch of things that come before it. That's really what I'm showing you here, okay? And so what G computation does is it generates follow-up under an assumed causal ordering, which I'm showing you implicitly here. X comes first, and then bleeding comes, and then conception, right? So I'll get into every node. But just think of this very generally as how I'm using my baseline data and all of the variable values that I have at week 1 on follow-up, and I'm basically using this to create follow-up over the 80 weeks that I have in my study, right? So I fit a model for my propensity score, for my exposure, and then I use that model to predict what X would be for any given person in my study. And then based on that predicted X, I use that plus all of the baseline information to predict what bleeding might be for my week M of follow-up. Based on these predicted values and these observed values, I then move on to predict whether a woman, well actually no, here I check to see in the previous week if a woman was pregnant. Pregnancy in this case, in this context, is what we call an absorbing state, which basically means that once they get pregnant in the study, they don't get unpregnant before follow-up ends. And so if they were pregnant in the previous week, then they're going to be pregnant in the subsequent week. So if yes, then they're pregnant here. But if not, then we predict whether they're going to become pregnant in that week. Right? So say that the woman wasn't pregnant in the previous week. Say this is the first week on study. M is equal to the first week on study. So that will channel us to this particular node, and we predict whether they're going to become pregnant in week M. And we basically just keep doing this. We keep predicting subsequent variable values, what they would look like. Would they have withdrawn from the study? That's our censoring node. If yes, if no, sorry, so this is CM equals 0. So if they didn't withdraw, if they did withdraw, that's the end of it for them. If they didn't withdraw, then they can move on to start experiencing some of the events that were defined in the trial, right? So if they did not withdraw and they were pregnant, they could have experienced a pregnancy loss. If they did not withdraw but they were not pregnant, they could have experienced end of follow-up without pregnancy, right? If they were pregnant and didn't experience a pregnancy loss, they could have experienced a live birth, right? So I've just simulated data using this algorithm here for a given week on study. And now we've gotten to the end of our algorithm. What do we do next? Well, actually, we have to either say stop if M is 60 or 80 or whatever the end of the study that we're trying to simulate is. But if it's not the end of follow-up that we're trying to simulate, we go back and we advance the week by 1, and we repeat the process all over again. So I hope this was intuitive. Ask questions. Basically, this is what the G formula is. It's using models that we fit in the original data to build up a simulated follow-up using this kind of reasoning, right? Okay, so but now how do we estimate effects? It turns out it's quite easy using G computation. All we have to do is, instead of simulating the follow-up that would be observed, instead of simulating the compliance that would be observed, we set their compliance to what we want it to be. So here, we'll say, let's set X to be 1 for all of those people who were assigned to treatment. And then with that, we are able to simulate the follow-up that would be observed if everybody complied with treatment. Same thing for placebo.
Is there any plausibility that aspirin, say, after 24 weeks of pregnancy, has any impact on life expectancy? And this seems to be a very fantastical model that is not associated with the biological. Biological probability.
So that's a good question. After 26 weeks with live birth, I don't know. However, if it's not, if we've modeled this correctly, we should be able to see that in our data. So we don't necessarily have to impose zero association between aspirin at 26 weeks and live birth in order for us to detect zero association. Do you see what I'm saying? We can be flexible with regards to that.
The only biological model proposed is an association with eclipse. Now you're freeing yourself of this association, and you're presuming there could be other unexplored associations.
Oh, okay. So we need to maybe take a step back and ask what you mean by biological model, right? So if what you're referring to is the potential for aspirin to change, say, inflammatory parameters in the body, and thereby modifying reproductive organs in such a way that live birth or pregnancy loss are either more or less likely. That's the motivation for all of this. That's kind of what we're assuming is happening here. The question is that really happening? If it is happening, is it happening to an extent large enough that we would be able to detect it in our sample? So all of this is based on that kind of an assumption. But we don't need to know the specific biochemical pathways that were involved in transmitting the effect of aspirin to the reproductive organs and thus optimizing pregnancy outcomes. We don't need to know any of that. All we really need to do is correctly get the confounding variables right. Well, there's actually a lot that we need to do. We have to get the confounding variables right. We have to get the models right. There are a lot of assumptions that are going on behind the scenes that I'll discuss a little bit more of later.
Mainly talking about time.
Well, I'll show you those results, and if you have concerns, then raise them then, because in fact, we chose a wide window for a specific purpose, because we actually anticipated that some of our effects at some point would become zero, yeah. Other questions? Okay. So for everybody who really likes math, this is the G formula. Basically, this is how I determine what models to fit, and I'm happy to talk about it, but you can ask any questions that you want. I'm going to skip it though. Okay, so with this G formula, or this general algorithm, I generated estimates of risk, or estimates of probability, right, under the following scenarios. First was a natural course. So this scenario is basically, I want to see what the risk would have been if they would have done exactly what they did in the trial. Why did I do that? Because if I can't model the risk that we actually observed in the trial, why would I believe the model that I'm using for risks that we're trying to get under hypothetical conditions where everybody complied with placebo versus everybody complied with aspirin, right? So really what this is a validation step. It's just me checking to make sure that I didn't make too many big mistakes so that my risks are all over the map compared to what we actually observed, right? The next protocol that we examined, or the next risk that we generated, was the risk that would be observed if all women were assigned to placebo and they took placebo. Next, we did the same thing for if they were assigned to low-dose aspirin and they took aspirin, and then again, we did what happens if they took it at 6, 8, 12, and 20 weeks. We also obtained 95% confidence intervals using the bootstrap. So I'm now going to present the results. We're going to start with several figures that look a little bit like this, and then we're going to get into some tables, and then I have some other figures that I'm going to show you. Let me explain what we're seeing here. So what I'm showing you is the risk of 3 outcomes in one figure. It's a little bit maybe too dense, so I apologize. But this risk is being accumulated over the course of follow-up. Okay? And what this is showing you, this gray area here is showing you the risk of pregnancy loss as follow-up progresses. Right? The white area is showing you the probability of live birth as follow-up progresses. And taken together, these two show the proportion of women who conceived in the trial. At the end of follow-up represents the proportion of women who conceived in the trial. Right? The dashed line is the actual observed risks or probabilities that we saw. So using just a simple cumulative distribution function estimator, we get these dashed line results. The dark lines are the results that we get from our G computation algorithm. Right? So basically what this is saying is we are actually able to replicate the natural course fairly well. And we're able to replicate it roughly at every week over the course of follow-up. So there are no serious deviations between what we're estimating here and what we actually observed. So for me, this is saying things are going well. Next, this is what would happen if everybody were to take placebo throughout, right? And so you can see that pregnancy loss goes up a little bit, and live birth changes, but not by very much. Right? And then here we have the risks or probabilities if everybody were to take aspirin throughout. The risk of pregnancy loss goes down, the risk of aspirin increases. The probability of live birth increases. Okay? So it's hard to get a quantitative sense of exactly what's going on here, so I'm going to present these same results in table form. So these are just a reminder, the intent to treat results, just to show you, these were the same results that I presented early on. So as you can see, no pregnancy loss effect, slight live birth effect, and slight hCG pregnancy effect. Right? So here are the per protocol results. We're actually seeing a very different pattern emerge here. Okay? So from the ITT perspective, being assigned to aspirin versus placebo for every 100 women in the trial, we have roughly 4 more live births among those who took aspirin versus those who took placebo. With these per protocol results, what we're seeing is roughly 15 more live births if all women were to take aspirin over the entire course of follow-up versus if all women were to take placebo over the entire course of follow-up. Similarly, we're seeing a reduction of about 6 pregnancy losses per 100 women in the sample and an increase of about 8 conceptions, 8 hCG conceptions. Does that make sense? Okay, so now what I've done is I've taken these results and I've put them in another graphical format. So here you're seeing point estimates and confidence intervals for different scenarios. So down here I'm showing you the intent to treat result. This is the result that I just presented in the previous table, the aspirin throughout result versus placebo throughout result. And here I'm showing you the results under the different scenarios for the timing. So what would happen if they took aspirin and then stopped once they conceived? What would happen if they took placebo and then started taking aspirin once they conceived? And then what would happen if they started taking aspirin at 6 weeks, 8 weeks, 12 weeks, and 20 weeks. And the outcome here is the conception outcome, right? So clearly, everything from here up, we would expect to see null results because it's too late at that point. Once they've conceived, taking aspirin can't affect whether they're going to conceive or not, right? And that's what we're seeing. We are seeing that taking aspirin prior to conception and then stopping at conception has roughly the same effect as taking aspirin throughout, right? On conception, yes. So what this is saying is that the effect of aspirin on conception is primarily prior to conception, and the effect is pretty much the same. This is not magical, yes. Sort of thinking of it as, let's make sense, does the model, so if, for example, we saw this out here, this would suggest a problem. So again, you can think of these as somewhat model validation type things. Okay. This is for the live birth outcome. So again, ITT effect. Here I'm showing you what would happen if they took aspirin throughout. This is what would happen if they stopped taking aspirin at conception. This is what happened if they start taking aspirin at conception. And this is what would happen as the time at which they initiate aspirin increases. So you can see a general decline in the effect. I mean, it's not a huge difference, but it's a general decline in the effect. And for pregnancy loss, same results, or the same scenarios. What would happen if they took aspirin throughout? Here's what would happen if they stopped at conception. Here's what would happen if they started at conception and started at 6 weeks, started at 8 weeks, 12 weeks, and 20 weeks. Right? So these results are actually suggestive of the importance of timing, at least with respect to pregnancy loss. What we're seeing here is that you have to take aspirin early in conception in order to observe any effects. And if you start at the recommended time given by the ACOG guidelines of 12 weeks, already we've missed an important therapeutic window here based on these results. Okay. Okay, so the takeaway, aspirin seems to be beneficial for women who have experienced 1 or 2 prior pregnancy losses. We've noted a reduction in overall pregnancy loss, an increase in the live birth rate, and an increase in the conception rate. And based on the results that I presented in the previous figure, it seems that the ACOG recommendations for preeclampsia would not result in improvements for fetal loss and live birth. Okay, so that's the results that I have. So now we're going to talk a little bit about some of the nuances and limitations here. So the first and biggest limitation is the use of parametric G formula or G computation requires relatively heavy modeling assumptions. So in fact, to get these results, I had to fit 7 different logistic regression models. I had to model 7 different variables. Misspecification in any one of these models can lead to problems. And I don't, or no one knows what the true models are. So did we get them correct? It's helpful that we were able to replicate the natural course. However, that does not guarantee the models are not misspecified or that the models are correctly specified. Okay. The other big thing here is that we are actually analyzing this randomized trial data, but we're treating it like an observational study. Right? So we no longer benefit from the treatment exogeneity that makes randomized trials the gold standard. Right? Which actually means, in more epidemiologic terms, that we have to assume that there were no unmeasured confounders. This includes baseline confounders as well as time-varying confounders. This is an assumption that's not typically required in trials. Right? And you may have seen this very recent paper that came out, I think, last week in the New England Journal, where the authors were advocating for less reliance on observational studies and more reliance on randomized trials. And I read this paper, and I have to say that I cannot disagree with anything that they say in the paper. They make, claims about why randomized trials are the gold standard and how one can run into problems when analyzing observational data, and they're absolutely correct. But the question that I guess I'm going to leave you with is, considering the trial results that we saw and considering these results that I'm showing you, the protocol results that we saw, should aspirin be used to optimize pregnancy outcomes in women at high risk of pregnancy loss? From my perspective, our results suggest yes, that aspirin can be useful, and it should be initiated prior to conception. That's all I had. Thank you so much. You can, oh, sorry, I thought you were.
Hi, I'm Tamara. My question is, so this was studied with women who actually had lost pregnancy, 1 or 2. Do you think that the factor of actually having gone through some type of conception, the body made it easier to conceive again in a way that could affect this trial? That, the body did it once, and then that could help with another likely to have a successful birth?
I don't know. It's a good question. I mean, there are competing issues here. One is a possibility that having experienced a conception makes it slightly easier to experience another conception. But then the other one is, and I'm not sure what the evidence says about that. There might be evidence documenting that. The other, I think, more salient issue, though, is that women who have experienced pregnancy losses are at a much higher risk of recurring pregnancy losses. And so the reason that this exclusion criteria was implemented in the trial is that this is really the population of women who kind of need help getting pregnant and staying pregnant. And so I do know at the NIH, although I'm not involved with any of these studies, I do know that there are additional studies that are being done in a much broader population of women. It's a big international study, in fact, looking at preconception aspirin on outcomes, and it does not include this as a criterion for participation in the study.
I have several questions.
Yeah.
The question is, I may have missed that. The women that were included in the study had never had a completed pregnancy with a live outcome?
No, actually, a woman could have had a child.
Because early pregnancy loss associated with never having completed a pregnancy, the plausibility of the pathology may be different from women that had a full pregnancy that lost the
That's
pregnancy.
correct. Yeah, that's a good point.
So
That's
totally different
that I
set
didn't
of
mention.
conditions.
Well, I'm sorry?
The plausibility of a certain condition may be different in the two groups.
Yeah. So I can't, my guess about the motivation for allowing women who have had previous children into this trial is that they did not want to create, I mean, it was sort of like an initial trial looking at preconception aspirin. And it could be that there are really more fundamental issues at play if a woman has never been able to conceive and give birth to a child.
Was hypertension followed in this study, and
Yes.
can you correlate it with some of your results?
With?
Your results.
So hypertension was followed in order to monitor for preeclampsia risks. There were, I think, there were such a small number of preeclampsia cases that it ended up not being a major issue in the study. So basically, most of these women were normal tensive throughout pregnancy, so there was no correlation.
They were all singletons?
Prior to pregnancy,
Yes.
non-preeclampsia hypertension.
I think that may have been one of the inclusion criteria.
Inclusion or exclusion?
Exclusion criteria. So if you had hypertension prior, you were hypertensive that was not pregnancy related, you were not included in the study.
These were now hypothetical questions.
Yes.
Do you think the length of aspirin intake prior to conception might have had an effect? Because as you presented your models, it could be that they had started pregnancy 2 days before they conceived,
Correct.
or weeks before they conceived.
Or months, yes. And in fact, there were
Months.
Yeah.
So the interpretation of the biological effects of low-dose aspirin, short-term and long-term, are not the same.
Correct.
Are you able to look at length of utilization prior to conception as a variable of impact on some of your outcomes of interest?
That's a good question.
I really think that,
Yeah.
biologically speaking, intuitively, I would think there could potentially be an important effect there.
I see where you're going. So the answer is yes, we can look at the length of the problem is, because hCG pregnancy is an outcome in our study, the length of utilization prior to conception would be basically defined by the occurrence of that event, which means in order for us to create that variable, we would have to be incorporating information about the future, which from a causal inference perspective is a big no-no, because in effect what you're doing is you end up adjusting. The question is, if we were to start giving women aspirin at this time point, would they have a higher probability of live birth? Would they have a higher probability of conception or a lower probability of pregnancy loss? We don't know exactly when they would become pregnant at that time point. So if I were to do an analysis in which I first document when they became pregnant in order to create a measure of prior exposure to aspirin, it sort of creates kind of a selecting on observables feature of this analysis.
Perhaps for conception, not for early pregnancy and late pregnancy.
Not for early pregnancy loss or live birth. You might be right.
We take conception out of it.
You might be right. Yeah, I don't see any immediate problems with that. So, sure, you're right. We could do that. Yeah.
Hi, okay, thank you. I was wondering if one of the possible reasons why there was no results at intention to treat analysis was due to selection bias, if you believe that. And does this per protocol analysis do anything to account for selection bias?
Okay, so number one, it depends on what you mean by selection bias. So here's what I think you mean by selection bias, which is we're looking at basically women in Utah, right? Is that kind of? So lost to follow-up? Oh, okay. That actually, the intent to treat results were adjusted for withdrawal. So they were presented unadjusted and then adjusted, and there was no difference in the results. In this particular case, all of this was adjusted for loss to follow-up. So if we can assume that conditional on the variables that I've included in all of these models, that censoring is missing at random, then that should add no problems to this analysis. So in both cases, yes, there is a need to consider the censoring, but it was considered in both cases here.
I have a somewhat related question. I'm wondering if there are differential rates of compliance between the placebo and aspirin. I could imagine that it might be more difficult to adhere to aspirin. So then in that case, you might end up comparing the super conscientious people willing to adhere to aspirin pursue like the moderate to super conscientious people?
That's a
willing
great
to
question,
adhere to
and there were very minor differences, so that I felt like I wasn't worth really presenting them. But we did definitely explore compliance over follow-up among those who were assigned to treatment versus among those who were assigned to placebo. And we did see that compliance was slightly lower among those assigned to treatment versus placebo.
Seems like in the per protocol analysis, the risk difference increased not only because of the aspirin user group having more live births or more pregnancies, but also because there were fewer in the placebo group. And I'm guessing that's because I'm taking into account their compliance as well. But I was wondering if intuitively you could kind of explain that, how there could be, if placebo is placebo, how there could be fewer live births, or I might not have seen it correctly, right? So risk is 43% of a live birth in per protocol, and what was the original analysis?
Yeah, so this is, you're looking at 43% and 58% compared to 47% and 50%.
I'm curious intuitively, if it's placebo and supposedly not doing anything, how, and I know it's due to the calculation, but how do you explain that?
So you're talking about this specifically versus this, right? Are those two different?
4 per 100.
Yeah. Yeah, I don't know. I think, yeah, you're raising a good point. The way I would answer that question would be basically to estimate the difference and then put confidence intervals around that estimate to see kind of the variability around that. It's 4.7. So this difference between live birth among placebo versus live birth if everybody would have taken placebo. Yeah, you're right. They're roughly tantamount to the differences that we're observing in the intent to treat analysis. But the intent to treat analyses were sort of confusing, largely because they're kind of inconclusive. So I'm not sure what I would make. I'm not sure that I would put too much of an interpretation on that. I mean, at the end of the day, we're generating these risks that come with a lot of variability, and so I don't have any biological explanation for placebo, complying with placebo, resulting in a lower live birth rate than if you were just assigned to placebo. Good question. Sorry. Other questions?
Thank you.
Thank you, everybody.